Hello, and welcome to the Clinical Care Options Infectious Disease Practicing Clinicians Exchange and Pro-CE Pharmacy Practice podcasts. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled 2023 Update, Principles of Outpatient COVID-19 Management. During this podcast, Dr. Renslow Sherer, Professor of Medicine at the University of Chicago in Chicago, Illinois, and Dr. Trinh P, Clinical Pharmacy Specialist at Emory University Hospital Midtown in Atlanta, Georgia, discuss updated information regarding COVID-19 testing, risk stratification, treatment options for acute COVID-19, and what we know to date about long COVID. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Sherer and Dr. Vu have to say about outpatient management of COVID-19.
Want to share and say Dr. Sherer and I are extremely excited to be back for round 2 of this presentation series. We had a great discussion on the first go around. A lot has happened since the fall, so we're excited to present some new data, reinforce some key treatment strategies. And with that, we'll go get started. So we'll start off by discussing the current state of COVID-19. And what we know right now is that the subvariant XBB 1.5 is the fastest rising subvariant, and it's more transmissible than prior subvariants. And this is because it has a higher ACE2 binding affinity and greater immune escape. And because of all of this, there's currently no effective monoclonal antibodies for prophylaxis or for treatment. But fortunately, there's no clear evidence that XBB 1.5 has any greater virulence or severity of illness. And then since we last spoke, there was also the introduction of the bivalent vaccine. So amongst those eligible, uptake of the vaccine booster, unfortunately, is low. So only 28% overall, and just 47% in those aged over 65. And so a study was conducted in Israel evaluating the effectiveness of the bivalent mRNA vaccine booster in patients above 65. And this was a retrospective study that evaluated 622,000 booster eligible patients from September to December. And out of that number, 85,000 did receive their booster, and out of those 85,000, 81% saw a reduction in hospitalization or death, and 86% saw a reduction in death. And so the numbers here tell us that the vaccine, the booster, is effective at reducing hospitalization or death. But as we saw on the previous slide, uptake numbers are poor. And so what we really want to emphasize is get the word out, encourage your patients and those you know who haven't gotten the booster yet to really get the booster. And we'll throughout the presentation, we'll talk about how the booster continues to provide benefits in many ways. So if you are 5 years of age or older, and it's been at least 2 months since your last vaccine dose, then you are eligible to receive a Pfizer or Moderna booster. And if you have a younger patient between the ages of 6 months to 4 years and they completed their Moderna primary series, that patient would be eligible for a Moderna booster if it's been at least 2 months since their last vaccine dose. And of note, people who are immunocompromised do have different primary series and booster recommendations, so highly encourage to go on the CDC's website for those recommendations because they are constantly being up to date. So next we'll move on to testing and risk stratification. Early diagnosis and early testing is important because the earlier you find out you have COVID, the sooner you can start treatment and increase your likelihood of preventing progression to severe disease. And so we have this beautiful infographic here to remind everyone of the clinical utility of the rapid antigen test. So with the rapid antigen test, we should utilize it in patients who are symptomatic or have recently come in close contact with those who have tested positive. And if your test is negative, then you can consider repeating that test in 3 to 5 days if the patient is still symptomatic or if you think it may be too early in the course to have detected a positive test. And then if the test does come back positive, then you want to interpret this as a true definitive positive and start your isolation process. And then of note, a long-standing positive test of over 10 days may just represent a non-infectious viral particle, and patients may not actually be infectious at that time. So first, you want to assess what the patient's risk factors are for severe disease. And if the patient does not, then you want to evaluate their symptoms. If the patient does not have moderate or severe dyspnea or any hypoxia, then the patient does not need any COVID-19 specific treatments, but you want to ensure they have scheduled telehealth visit follow-up. And if this patient, again, does not have severe risk factors for severe disease, but do have moderate or severe dyspnea or any hypoxia, then you actually want to refer them to the ED for escalation of care. And if your patient does have risk factors for severe disease, again, you want to think about symptoms. So does the patient have moderate or severe dyspnea or any hypoxia? And if the answer is no, then you want to evaluate when did those symptoms occur. If the symptoms occurred outside of the 5-day window, then no oral antiviral treatments are indicated, but the patient may be a candidate for IV remdesivir. So you can discuss that with them to see if they qualify. And then if symptoms have occurred within 5 days, then patients may be a candidate for oral antiviral treatments. Either treatment that they receive, these patients should receive scheduled telehealth follow-up to ensure their symptoms have not progressed and that they are feeling better. And then if the patient does have risk factors for severe disease and does have moderate or severe dyspnea or any hypoxia, again, that patient should be referred to the ED for evaluation, possibly for escalation and care. And so I want to highlight is that for any patient who have, whether or not they have risk factors for severe disease, if they are showing signs of moderate or severe dyspnea or hypoxia, then there's no outpatient treatment that's currently recommended, and you want to refer them to the ED. The outpatient treatment that we have for this patient population really is for those with severe disease without severe symptoms and but are at risk for developing progressive disease. And that's where our treatment options come into play in the outpatient setting. So the very first thing we want to evaluate is their risk factors. And so what we do know is that age is the strongest risk factor for severe COVID-19. And we can see here on the slide, this shows a COVID-19 death risk ratio for select age groups and for comorbid conditions. And in blue up top, the death risk ratios are separated out based on the age groups. And we can see that as the age group increases, the death risk ratio also increases. And we want to highlight that patients above 65 years of age have a death risk ratio of 6.7 times. And that number continues to increase again as we go up the age scale. And then when we compare that to the other comorbidities listed, the numbers are significantly lower compared to age. So again, I want to emphasize that age is a very strong indicator of or risk for developing severe COVID-19. And then in the two studies that we'll talk about later on as well, but the EPIC-HR and Move Out trials, they had some criteria for what they defined as high risk, and age over 60 was one of their criteria, along with others that are listed. And then some of the other risk factors for severe disease are listed here. Some of the ones I want to point out, which is important because these would be very common amongst the general population. So cardiac disease, diabetes, and this could be type 1 or type 2, overweight or obesity. And if patients were a current or former smoker, again, all of this puts them at high risk and potentially could be a candidate for an outpatient antiviral treatment. Now we'll shift gears and discuss what the guidelines recommend in terms of treatment. So the NIH guidelines suggest the following for patients who are non-hospitalized with COVID-19. And so if patients have high risk of progressing to severe COVID-19 and are not requiring supplemental oxygen or hospitalization, then the NIH recommends, and this is in order of preference, nirmatrelvir, ritonavir within 5 days of symptom onset, or remdesivir within 7 days of symptom onset. Now, if neither of these two options are available, then you can consider molnupiravir within 5 days of symptom onset. And the IDSA and the NIH do have some recommendations against the treatment of non-hospitalized patients with COVID-19. So the IDSA specifically mentions that patients with COVID-19 or in the outpatient setting to recommend against hydroxychloroquine or chloroquine and ivermectin. And then the NIH also has some recommendations against, and they also, their recommendations are really dependent on the patient population. So if your patient is not requiring hospitalization or supplemental oxygen, then the NIH recommends against starting steroids. If there's a patient who's been discharged from the inpatient setting who's otherwise stable and improving, and this is with or without supplemental oxygen, then the NIH recommends against continuing baricitinib, remdesivir, and dexamethasone after discharge. And then for all non-hospitalized patients, the NIH recommends against metformin. Although I will say if your patient is on metformin, for a non-COVID-19 condition, then of course they should continue this medication under the supervision of a healthcare professional. Dr. Sherer, I'll go ahead and turn it over to you.
Thanks so much, Trinh. So thanks for a terrific review. I think I'll just reinforce the points that you made, at least two of them. One is that it's discouraging that vaccine uptake has slowed, particularly with our with a booster that's available. And so triaging our efforts to update vaccines, particularly for those who are over age 65, those who are immune compromised, or those who have substantial comorbidities, is clearly an effective use of time. I'm going to add some information that sort of adds an argument that you can use with your patients. I think that's quite important. And I appreciate in your thinking of who fits this high risk but non-hypoxemic and not with rapid ventilatory response. There are all these other reasons that a person who might have COVID would go to the emergency room. And I think it's important just to refresh our memory that you can present with a cold limb or a seizure or chest pain that's because of a myocardial infarction during an acute COVID episode. Lots of other reasons that somebody might need still to go to the emergency room, and it's very important to tell them to do that. Others are intractable vomiting or high fever. So to make sure that we're just selecting the right patients who should be cared for in the outpatient setting. And I see now that we do have some questions, so I'll come back to you, Trinh. One is, how does metformin help with COVID? And I'll start, and then maybe you would add. I think the point of that IDSA slide is that actually there's no evidence that it does. There's been a few well-conducted clinical trials that have found that it adds no additional benefit. But if somebody's already taking metformin, then I think it's quite reasonable as a diabetic for them to continue that medication. Do you have any other information about metformin in use against COVID?
Yeah. So I think the spark with metformin in the first place was that there are some thoughts that it does have some possible anti-inflammatory effects, and that it possibly could interfere with the translation process of antiviral replication process. And so because of that, I think there was some spark in interest. But like Dr. Sherer said, and that's why the IDSA also recommends against it, is because the data have shown no added benefit.
Okay, here's another question. My facilities had limited access to remdesivir in the outpatient use. Have there been national shortages?
That's a great question. I am not aware of any national shortages. Of course, ASHP updates their shortage guidelines very frequently, but this is just not something I'm aware of at the moment.
Okay. I think it's a really interesting question. Asks, when should we do a telehealth visit in this context? And maybe you'd speak to that, Trinh.
Yeah, I'll speak to it. And then if you have anything else to add, of course. But once the patients have completed treatment, probably within the next week or so, the following week, just to make sure the treatment has been thoroughly completed. And that's the most important part. If it is their oral treatment option, ensure that patients did complete their 5-day course. And then within a week or two following that treatment, just to ensure they had no side effects or tolerate the treatment well, ensure they completed treatment, and also that symptoms had not progressed. Of course, if patients do have progressive symptoms, then they can reach out way before that time frame. But I think within a week or two is reasonable.
Great.
Anything else you add? Yeah.
Yeah. No, I completely agree with the points that you made. And I see two additional questions that actually involve some of the material that I'm about to present on the question of, shouldn't we be treating some standard risk patients too? There's some evidence of benefit. No, I'll cover that. And then a skeptical comment, if there are only 289 hospitalizations out of 600,000 people who were not boosted, that's a pretty low risk. So, what are the risks associated with the use of the booster? I think referring to adverse events, and the adverse event profile is exceptionally low. So these are extremely well tolerated arthralgias and a low-grade temperature in a small fraction of people, and those are the most common. But the other incidents of serious, for example, myocarditis, are in the range of between 1 to 10 in a million people, so exceptionally low risk of severe adverse outcomes. But I think it would be a good idea to move ahead, and then we'll get into some of those comments. I'm going to move on to talk in a little more detail on the treatment options that Trinh has just shared with us. Just to remind everybody that we have several different phases of COVID. There's the early infection where it appears that it's viral replication that is causing most of the signs and symptoms, the lymphopenia, dry cough, fever, etc., where our goals really in this patient population, the ambulatory population, is to reduce further extension of disease, hospitalization, and morbidity and mortality. And just to remind you that then most patients will enter a pulmonary phase if they are continuing to have clinical signs and symptoms, and that's about 1/5 out of everybody who's infected. And then even a smaller number who enter this hyperinflammatory phase where a number of other options have been shown to be effective. For example, steroids and the use of some of the immunologically active agents. So we're focusing on this area in the box, treating early infection. And the reason that it's useful to look at this time frame is to remind clinicians about the limited amount of time within which to use these agents. As you heard from Dr. Vu, they really need to be used within 5 days to be effective. And I think that's the take-home point there. So this is a summary of 3 different studies that shows the relative benefit in terms of the reduction of hospitalization or death compared to placebo with the nirmatrelvir, ritonavir, when used either at evaluated at 3 days after use or 5 days. And you can see extraordinary benefit, 89% overall reduction in the risk of hospitalization or death with nirmatrelvir and ritonavir, highly significant difference compared to placebo. The Pine Tree study with 3 days of remdesivir in high-risk patients who were mild to moderately ill, with up to 7 days of use, again, with a very high reduction of 87%. And then with the molnupiravir move-out study, again, with using that drug within the first 5 days, a reduction of 30%. So less impressive, less efficacious overall, but still active. And so for that reason, as Trinh mentioned, the NIH guidelines give us a hierarchy of recommendations, really based on what's easiest for us and for our patients to use with the least amount of clinical encounters. So for non-hospitalized patients, for people at risk of progression, and I want to reinforce Trin's list of anyone over age 65, anyone with age 50 and substantial comorbidities. But understand that that comorbidity list includes, for example, juvenile onset diabetes. So I've treated people with juvenile onset diabetes in their 20s and 30s. That age limit is no barrier if someone has a substantial comorbidity that puts them at greater risk. Another example is pregnancy, and yet another is any immune compromised host. So we really have a fairly large group of people. The second alternative is the IV remdesivir option that was shown in the Pine Tree study, but that is over 3 different days as an outpatient administration to be used within 7 days of symptom onset, with very good evidence in support of its use. But it has to be administered in a healthcare setting, and there's logistic barriers for the use of that drug. And, I think it's important, the last bullet on this slide mentions that if you're triaging the use of these agents, clearly unvaccinated patients have the most to gain as compared to those who've been vaccinated. But I'm going to show you data that suggests that even in the presence of vaccination, there is substantial benefit. And so the alternate treatment, as we've talked about, if neither of those two are available, and there was a question earlier about the availability of remdesivir. We did have issues with distribution and shortage earlier in the epidemic. Most of those have been overcome, not all, but most. And so I would say you're more likely to have access to all 3 of these drugs in your treatment area. So in the event that you don't have nirmatrelvir, ritonavir, or remdesivir, then the molnupiravir option is mentioned. That's twice a day for 5 days. For those who are over age 18, it has to be used like the nirmatrelvir, ritonavir within 5 days of symptom onset for efficacy. It's clearly lower efficaciousness than with the other 2 drugs. And it has a substantial black box warning for use in pregnancy. And when used in women of reproductive age, we should be sure that they're on effective contraception in that limited setting. So, but because of the lower efficacy, the other 2 agents are clearly preferred. So there's evidence that's accumulated on symptom duration in that very first study that we talked about, the EPIC SR, those folks with substantial risk. There was not an endpoint of symptom alleviation in the first 4 days. In contrast to that, in both the remdesivir and the molnupiravir studies, there was significant shortening of time to symptom relief and improvements in the severity of symptoms. And you can see that that was true both in the Pine Tree study and also in the Panoramic study, where there's improved time to recovery of 4.2 days, as well as reduction in virus load. And that was in the setting of 94% of people actually being vaccinated. So I'm going to press ahead. Unless, Trin, are there any questions that I should take on now, or should we keep going?
I think we're getting some good questions, so we can tackle some, I think.
Okay.
Let's see. We have a question about vaccination. So how long would you recommend to wait after an episode of acute COVID to vaccinate with the booster?
Yeah, it's a very good question. There's clear evidence of some level of natural immunity. There's a debate and actually a sort of bell-shaped curve onto how much and how long it lasts. 2 months seems to be a reasonable standard, both after vaccination as well as after a recent episode of COVID-19.
Okay. And then we have some questions about rebound, which we'll further discuss later in the presentation. So we'll address that. We have a great question, and I'll read this one out to you. So
Okay.
and I'll be interested to see what your take is, and then I'll respond as well. But in my practice, I have had 2 patients refuse vaccinations, stating that one of their relatives died immediately after a vaccine. How do I respond to these statements? Another barrier to vaccination and a reason for decline in vaccinations in my area are that people who are fully vaccinated and fully boosted are contracting COVID, even contracting it 2 times. They are questioning the efficacy of the vaccinations.
Great. I want to take the second one first. This is nobody's fault, the sort of level of confusion among our patients, because we're used to vaccines preventing both the acquisition of a new infectious agent as well as reducing the severe consequences. With that last question, you can use the influenza vaccine, which we've known for a long time is best at preventing death and preventing hospitalization. And while it reduces the chance that someone will contract influenza, it doesn't eliminate it. And what we've seen as we've lived now for 3 years with SARS-CoV-2 is that it's gotten smarter. These new mutations leading to Omicron, their principal value for the virus has been to increase infectivity and to get around the impact of past viruses and of natural immunity. So we understand that there's a small benefit in the use of current vaccines to reduce the chance of infection, but it's still very common, as has been seen, that people get vaccinated and they still contract it, which is annoying. So they have to deal with the likelihood of the potential for them to spread. There may be time off work needed. They're masking and just the new, it's an annoying reality to have COVID yourself or in your family. But, and I'm going to reinforce this evidence, the vaccines and the boosters are exceptionally effective at preventing the course of severe illness and death. And again, they are not perfect at that. We are seeing that there are occasional patients with breakthrough who go on to have serious illness and even to have deaths. Those are largely age over 80 and folks who have serious levels of immune compromise. But we don't want to let the perfect be the enemy of the good. And so one of the ways that I tackle that is to say, you don't want to go in the hospital. You don't want to have a serious illness, kidney failure, some of the other consequences of COVID. And the vaccines will prevent that for you and your family and your children and your loved ones. It's a much harder answer for the first patient who says, I had a friend of mine or a family member who got the vaccine and then had sudden death later. This actually came up with a very famous case of the athlete, the football player who had that happen to them. There are events that occur because we're vaccinating such a large number of people. They may have temporally related events where there's a sudden death from someone who's had a vaccine that's entirely unrelated. And that was the story in the case of the athlete with the Philadelphia Eagles. It turned out that there wasn't even a vaccination proximal to that event. That was a very rare cardiac associated reason for a collapse and of course it wasn't a death. It was a sudden cardiovascular collapse. So I think what you do in that setting is you present the evidence that we have. What is for milder side effects and then for severe side effects, it's a very important data set to have. But the rarity of those events means that the consequences of COVID, even in this era with vaccination, are much more serious and more likely to occur than a serious event with vaccination. And I really appreciate that question. And maybe I'll suggest, Trinh, we go ahead and cover that because I know there are a couple of these other questions that are related to the material I'm about to cover. Then we'll get back to them. Comparing the three different antiviral medications that we've just talked about, with nirmatrelvir and ritonavir, there are important drug interactions that are, for the vast majority of patients, they're not deal breakers. They are something to think of and to take into account. And for the vast majority of them, we have good strategies for either temporarily holding medications or where we know people can be safely continued on their medication but monitored. I'd say the red box here is just to illustrate the very significant importance of timing so that when these drugs are used, you really only have a 5-day window to use nirmatrelvir or ritonavir or molnupiravir before that expires, and they're not going to do very much good. So you really want to make this decision in the first day or two following infection in those folks who are at higher risk. And with remdesivir, you have a couple more grace period, up to 7 days before symptom onset. There's a few other things that are useful, I think, on this table. Occasional adverse events can be fullness in the belly and loose stool, which often are addressed when you administer it with food. It's not much in the way of adverse events with molnupiravir, a little bit of nausea with remdesivir, but these are actually quite well tolerated medications. There are adjustments for renal dosage in people who are using nirmatrelvir and ritonavir that are mentioned there, where you can adjust the dose. And at the very end of people with chronic kidney disease and low glomerular filtration rates that are not recommended. Similarly, remdesivir is not recommended at the lowest eGFR, though I believe there is evidence that that's changing. And that leads me, so again, I'd say the duration is the take-home point on this slide of trying to get therapy decisions made and treatment within 5 days for nirmatrelvir and ritonavir or molnupiravir, or 7 days for remdesivir. So this EPIC HR, meaning the high-risk non-hospitalized patients, the study using nirmatrelvir and ritonavir, you can see that people were either randomized to a placebo or getting the drug twice a day for a period of 5 days. In this case, people aged 18 to 59 with at least one or more comorbidity that might predispose them to severe illness, with the primary endpoint being either hospitalization or death. And data were also collected on adverse events, and these were the outcomes. You can see that the numbers for those by day 3, if they were started, there were 5 hospitalizations or deaths in the treatment group compared to 44 in the placebo arm, and by day 5, 8 and 66 respectively. And if you look at deaths overall, there were no deaths in the treatment arm compared to 9 in the placebo arm by day 3 and 12 by day 5. And that to me is very powerful information in support of the indication for 5 days of a medication that can actually prevent deaths in a substantial number of people. Someone earlier said, yes, but there's a lot of people, and that's true. We were talking about in these cases, 697 in the first group, or 1,000 total, but 12 deaths out of 1,000, that's 1%. So that to me is a very strong reason to offer this to patients and to tell them of the need. And again, to reinforce that it has to be done within those first 5 days. So it was asked earlier, why don't we treat standardized patients? And one of the reasons is in this cohort, very similar design, but this was a group of people who had standard risk, who didn't meet that high risk threshold, that the overall, and also were fully vaccinated. And you can see that the primary endpoint, that is symptom alleviation after 4 days, was not met. And there was a trend, a secondary endpoint, towards a 62% decrease in medical visits, which was both ER and primary care visits. There was also a 57% reduction in hospitalizations or death, but there were very few events. So you can see that it was 3 out of 361 in the group that got treated, again around that 1% figure, compared to 7 out of 360 either hospitalized or died. So that's 2% versus 1%. And I think you and your patients, if you're inclined to be very risk averse and want to take every step to avoid hospitalization, you could reasonably choose to treat in that setting. Let me go back to a point that Trinh made. This is really important, but again, I think this has rarely led to my not being able to use nirmatrelvir and ritonavir, which is the easiest to use because it's outpatient for our patients. On the left, there's the short list of drugs that are contraindicated. And I think some of these are quite important. For example, patients on cancer and cancer chemotherapy, it might be prudent in that setting to prefer remdesivir or molnupiravir. So the simultaneous administration is contraindicated. But for most drugs, they fall into this other category of either you can freely use, which is the majority, or you want to use them with caution. You want to monitor drug levels, for example, with digoxin, with methadone, with some immunosuppressants like tacrolimus. So in this case, always you're going to want to go through the interaction checker. You can see the Liverpool site where you put in the extra drug and it'll tell you how to manage that, whether it's withholding medications. For example, some of the statins, it's recommended that we hold lovastatin or atorvastatin for the 5 days and 2 days during the administration. But otherwise, the drugs can be used in that setting. So there has been some more recent data. This is some of the newer data that Trinh mentioned. This was a study from the New England Journal last year looking at nirmatrelvir and ritonavir in my age group, people over age 65. But this is during the Omicron era. And the majority of these folks, you can see, are the overall population. There's a 63% reduction in the risk of hospitalization. And in those who had no vaccination or one vaccine, that was even greater. That was an 85%. But if you look at those who were fully vaccinated at that time, still there was a 68% reduction in the risk of hospitalization. So, to me, that's persuasive that that's enough benefit that 5 days of medication is a very reasonable step to take. This was another bit of data from the CDC using electronic records out of almost 700,000 Americans over age 18 from April to September 2022. Again, during the Omicron era, looking at hospitalization rates. And this sort of strategizes it by age over 65, where by far the greatest benefit was observed in like a 47% overall improvement. But you see also benefits with those who were age 50 to 64 and age 18 to 49. So by far and away, there were more hospitalizations in the oldest age group. You can see that in this group, there were 28% of people who received nirmatrelvir and ritonavir. And so the treatment clearly was beneficial in each of these groups. And the most marked improvement was in the age over 65, where it was 29.7 people in the treatment group compared to 68. So a substantial reduction. There were also impressive reductions in the range of more than a 50% reduction in the age group, just 50 to 64. So I think, again, in answer to that question that was raised earlier, shouldn't we be thinking about treating in some people who aren't over age 65, who may be over age 50? I know many clinicians have used that as their preferred threshold. So with that, I'm going to stop and turn this back over to Trinh, and then we'll answer some questions when she's finished.
Sounds great. All right. So now we'll move on and talk about remdesivir. So, and more specifically, the Pine Tree data for non-hospitalized high-risk individuals. And this was a randomized study conducted at 64 sites internationally, and patients were assigned to either receive remdesivir or placebo in patients who tested confirmed positive and had a symptom onset within 7 days. And the primary efficacy endpoint was a composite COVID-19 hospitalization or all-cause mortality by day 28, and they also evaluated safety endpoints as well. And the data to support remdesivir's effectiveness it's strong. So between the two arms, baseline characteristics were balanced, and in high-risk non-hospitalized participants, a 3-day course of remdesivir prevented COVID-19 related medically attended visits, hospitalization, or death. And more specifically, looking at the table on the right, the relative risk reduction of COVID-19 related hospitalization or deaths in patients who received remdesivir was 87%. And there was no difference between remdesivir versus placebo in time-weighted average change in viral load by NP swabs. And in terms of safety, remdesivir has a great safety profile, well tolerated, and the most common side effects were nausea, headache, and diarrhea. Again, just a very highly tolerable medication. And as a matter of fact, if we're looking at the last row, comparing remdesivir to placebo, there were actually more patients in the placebo arm who experienced serious treatment emergent adverse events. Now, in the data we see that remdesivir is proven to be efficacious and also has a safe safety profile, but you always want to think about, well, how do I get this medication into my patient? So remdesivir, as we know, does come with some challenges and logistical barriers because the fact that it is a 3-day daily IV infusion. And some things you want to consider, and some of these challenges are that the location of infusion centers with availability. Patients need to have the mode of transportation to travel to and from the infusion center. And as these patients who tested positive are entering these infusion centers, we potentially could be risking exposure of COVID-19 to others who may be at the facility for a non-COVID reason. And then ensuring that there's adequate staffing to prepare the medications and to administer the medication. There's also some payment and reimbursement structures that could be unclear with remdesivir. Now, remdesivir, again, it has to be administered in a healthcare setting. And so there's different settings for infusion. It could be done in an inpatient hospitalization, outpatient infusion center, skilled nursing facility, and home infusion. And fortunately, the manufacturer does have some great resources available. So there is advancing access, and this is, again, directly through the manufacturer. And this could help pay for or provide financial assistance for some of your patients who may get remdesivir but need assistance there. And there's also some information on coding, reimbursement, and ordering remdesivir as well. And then for molnupiravir, we'll look at the Move Out trial, which studied in patients who are at risk and non-hospitalized with COVID-19. So patients received molnupiravir for a 5-day course. And again, these patients are tested positive, but their symptom onsets were within 5 days. And the inclusion criteria included patients aged 18 to 60 with at least one risk factor of developing severe disease, and age over 60 was considered a risk factor. And then some of the primary endpoints were percentage of hospitalization and or death by day 29 and adverse events. And in the final analysis from the study, it was found that in non-hospitalized at-risk patients with mild to moderate COVID-19, molnupiravir given for 5 days reduced the risk of hospitalization or death by 30%. And molnupiravir, as we know, did receive EUA approval in December of 2021, but only for use as an alternative therapy if the other two agents are not accessible or clinically appropriate. Molnupiravir, as previously mentioned, can cause fetal harm. And so there are some pregnancy and contraception considerations when you're thinking about molnupiravir as a treatment option. So in females or persons of reproductive ability who's taken molnupiravir, you want to ensure they have a reliable and consistent method of contraception during their course and 4 days after. And then for males, it would be consistent method of contraception during their course, but also 3 months after completing their treatment course. And molnupiravir is not recommended for use during pregnancy, again, because it can cause fetal harm. And if individuals are breastfeeding, you want to counsel them to pump and discard their breast milk during their treatment course and 4 days after. All right, so next we'll move on and discuss rebound. There is a potential for symptom rebound following nirmatrelvir, ritonavir use. And so in a retrospective review conducted at the Mayo Clinic in patients who received nirmatrelvir, ritonavir for mild to moderate COVID infection, in this cohort, the median age was 63, and it was almost evenly split male-female, but I want to highlight most of these patients were fully vaccinated. And most patients also received nirmatrelvir, ritonavir about 1 day following their positive test. Rebound is defined as a recurrence of COVID-19 symptoms following completion of 5 days of nirmatrelvir, ritonavir. And what the study found was that only out of 483 patients, only 4 experienced rebound. And again, all 4 were fully vaccinated. The median time to rebound after treatment was 9 days. But it's important to note that all resolved without hospitalization or needing additional COVID-19 directed therapy. All 4 just received symptom-targeted treatments. And all 4 patients also had multiple comorbidities. And then in another study, this study wanted to evaluate not only nirmatrelvir, ritonavir, but also molnupiravir and its rebound effects. And so in a study of 13,000 adult patients who received either molnupiravir or nirmatrelvir, ritonavir, what we found is that for both oral antivirals, the COVID-19 rebound increased with time after treatment. So we can see the two antivirals listed side by side. The first number represents day 7, and the second number represents day 30. And I want to point out there were more patients in the nirmatrelvir ritonavir arm, 11,000 patients in that arm compared to just 2,000. But again, we see that the rates of rebound infection, symptoms, and hospitalizations were higher at day 30 than at day 7. And also what's important to note as well is numerically, rates of rebound infection, symptoms, and hospitalizations were actually higher in the molnupiravir arm. And so this study just highlights the fact that I know nirmatrelvir, ritonavir more frequently is associated with rebound, but the study just highlights that rebound is not unique to just nirmatrelvir, ritonavir, and it can occur in patients after taking molnupiravir as well. And then for rebound, we know that it can occur in the presence or absence of antiviral therapy, and we'll actually discuss that in the later slides. But what we've seen is that it does occur at very low frequency. It's important to point out that patients may still be infectious during this rebound period, and that positive cultures can still persist after their treatment course. And rebound is a phenomenon that is not well understood. There are lots of different theories out there to explain why this happens. And again, it's not fully understood, and it may be multifactorial. And so it really can't easily be explained by impaired immunity or resistance mutations alone. So a study was recently published, just a couple of weeks ago, actually, evaluating symptom and viral rebound in patients with untreated COVID-19. And this study included 563 patients. And what we see in the graph on the right is that 31% of patients who were untreated with COVID-19 did experience viral rebound with an increased viral load of over 3 logs copy. And then 13% or 1 in 8 participants did experience high viral rebound. And this is defined as a greater than 5 increase in log copies. And I think this is an important slide here from that same study. This slide shows the rates of symptom relapse and viral rebound in patients with untreated acute COVID-19. And so we see the diagram on the left shows symptom and viral rebound after study day 0. And 26% of patients actually experienced a rebound, and 13% experienced high-level viral rebound, but only 3% experienced both. And the numbers are pretty similar at day 5. 22% experienced symptom rebound, and 7% experienced high-level viral rebound, but only 1% experienced both. And I think the results of this study highlight that although waxing and waning of residual symptoms is common after patients recover from COVID-19, the likelihood of experiencing symptom rebound and high-level rebound is a rare occurrence. And then so that was rebound. And then just want to quickly touch base on the monoclonal antibodies. And so as addressed very earlier in the presentation, because of the variants and the evolution of these new variants, unfortunately, we've lost activity to the monoclonal antibodies have lost activity to these new variants. And tixagevimab, sugevimab, and in belretevimab as well, both have shown to lose activity against BQ1, BQ11, and XBB. And tixagevimab, sugevimab for pre-exposure prophylaxis is actually no longer authorized for use because of its data. And then sotrovimab also has lost activity against the different variants. And again, this just kind of highlights the fact that the variants are constantly evolving, and unfortunately, the agents that we did have available to help prevent or treat some are just no longer effective. And so I think it's very important to identify our patients who are at high risk to vaccinate. Test early on to ensure they receive appropriate treatment within those 5 to 7 day window because of this reason. And then take-home points for acute COVID-19 is that the SARS-CoV-2 variants remain a serious public threat, continues to evolve, and what we ourselves have to adapt to its evolution. Vaccination with boosters is strongly recommended. When symptomatic, timely diagnosis by testing is critical to informing treatment options. And risk assessment is essential to identify what treatments patients are eligible for. And again, we emphasize that important time frame because early antiviral treatment within 5 to 7 days, we know can reduce serious illness, hospitalization, and death. All right. So at this point, I'm going to turn it over to Dr. Sherer to talk about long COVID.
Well, thanks, Trinh. We do have a number of questions, so maybe I'll stop and ask. I'll answer a couple and then ask you before we get into long COVID. So if you're not vaccinated or not boosted, you're already in a higher risk for complications. And I actually endorse that. I think that's true, that we have lots of different ways of assessing risk. And if you're not fully vaccinated, then your risk of more serious infection does go up. And I think that would increase my sense of an indication for treating that individual. And then comparing molnupiravir and Paxlovid, since the efficacy is only 30%, would you try to use Paxlovid even if the patient has drugs and has some drug interactions? And I'll give my answer, and then maybe Trinh, you can answer because you're the pharmacologist, and I would be turning to you also. But in general, I would try to use to treat that patient with nirmatrelvir because of the benefits associated with it. It's short-term use, and as I mentioned, for the majority of interactions, it's manageable. The exact answer, I think, is, well, it depends on what those interactions are. If it's cancer chemotherapy, where I'm very reluctant to alter the dosage, then I would probably turn to an alternative. How do you answer that, Trinh?
Yeah, I 100% agree. It really does depend on, of course, what the drug interactions are. But in most situations, a 5-day course of Paxlovid can be utilized. And I think you can make the alterations, ensure there's appropriate monitoring. I think the great benefit of close monitoring nowadays is that we have telehealth to ensure we can closely follow up with our patients who do have those drug interactions. But I agree, the data really supports nirmatrelvir, ritonavir, and so we want to utilize that as much as possible. And if we can make modifications to their concurrent medications, we should attempt to. But of course, when it comes to chemotherapy or any medications you're a little hesitant to try to administer, then I would be hesitant only in those really rare situations if patients are on numerous medications on the contraindications list where modifications is not ideal.
There's a question on the choice of using dexamethasone compared to other glucocorticoids. And I'm really glad that you mentioned this. In some of the slides that Trinh had shown earlier, in the list of agents not to use in the ambulatory setting, there's actually good evidence that dexamethasone can make somebody worse in this setting. So we don't use steroids in the ambulatory setting for someone who's not hypoxic, who's not hospitalized. You're quite right that steroids have been shown to be effective in hypoxic hospitalized patients. And again, my answer would be there's several different types of steroids that can be used, and clinical trials have used a variety of different ones. It does not seem to matter if they're comparable doses, but that's a different patient population. So in this group that we're talking about of managing as outpatients, steroids are not recommended. And then, Trinh, there's a number of folks who want to ask not only about rebound, but the problem of testing and variations in test result. what are your thoughts on reports that patients who've taken Paxlovid or molnupiravir test positively 2 or 3 days after they started to test negatively at day 5? So not only did they have rebound, or symptom rebound, but they tested positive again.
Yeah, I think that's a really great question. And I think before we want to think about the fact that these tests are, of course, not 100% accurate. And so especially testing immediately after that completion course, the positive test may reflect rebound, but it could also reflect non-infectious viral particles. And I think that's also important to think about. But if the patient still remains symptomatic, then rebound is on the differential, and we want to be considering that. And if the patient, and if we think that the patient truly has rebound, and I would still ensure that the patient, again, did complete their nirmatrelvir, ritonavir appropriately, and encourage symptomatic management. If they have tested positive and remain symptomatic, there are, and the guidance isn't as clear, but you also want to consider resetting the isolation clock, because some data has been shown that even in instances of rebound, the viral replication is active and patients can still remain transmissive. And so you want to consider resetting that isolation clock to ensure they don't pass it on to other individuals.
Okay, give you one more question on testing. So if somebody has a positive home test, but then they repeat it 2 or 3 days later and they're negative, can they cut down their quarantine and are they free to go out? Maybe the most common question we get from our patients.
Yeah, that's a great question as well. And again, I just want to reemphasize the fact that the test itself may be showing a false negative. And I would really adhere to the 5-day isolation, only because patients can still be symptomatic and not symptomatic, but can still be shedding the virus at that time. It can still be have the ability to transmit that virus. And so I would still adhere to the 5 days. I know trying to cut down your time short is a very appealing option, but there are the possibility of potential false negatives or the inability to have done the test correctly. And so I'd be more cautious in that situation than not.
Very good. Yeah, I think it would be a good idea to let's get through. We won't answer all the questions about long COVID, I promise you that, but let's finish our deck, and then we have a couple of more questions that we'll have time to get back to. And I'm happy to try to finish with our shared ignorance about long COVID, which continues really to be a vexing problem in so many different ways. One is just simply, what is it and how should we define it? PISC stands for the post-acute symptoms of COVID, and it's also more informally been called long COVID, and I think we're now using them synonymously. But the question is, what should the definition be? So WHO has said it's new symptoms that affect everyday function that come 4 weeks to 3 months after the first acute COVID-19 infection, and then last for 2 months or more. And it's very important to recognize that these symptoms wax and wane. It makes it very difficult to define this epidemiologically or to see if there's a response to therapy, because they might get better for a few days and then return and get worse. One large debate is, should it include those people who had significant COVID-19 clinical signs and symptoms and were hospitalized? Many of those folks, a much higher percentage of those folks, have ongoing symptoms, have end organ damage like heart attacks or strokes or chronic kidney disease. I personally like to include them because that tells us about the totality of COVID-19's impact across a population. But there's good evidence that it may have divergent pathogenesis and therefore should be identified and studied. And so for those of us who are trying to follow this literature, make sure you understand what is the study group that's being presented as you think about long COVID. Does it include those who are sicker, who had post-hospitalization or not? It's very clear that we're going to need long-term follow-up for all of these folks with aggregated data from clinical cohorts, from medical records. Some of the reassuring news is that it appears that over time, the majority of cases are self-limited, and the majority either resolve or improve in 3 to 6 months. And I want to say very quickly that that doesn't eliminate the importance of those folks who seem to be in the minority, who really have profound disabling symptoms that can last for months. And so I think it's all of these different groups that we're concerned with. We don't have a good biologic marker for PASC or for long COVID. And so that means we're relying on these clinical definitions and their fluctuations. So this is quite important. The estimates of the incidence and prevalence have been as high as 65 million people worldwide. That's a conservative estimate of 10% of the 651 million people who've been documented dead COVID-19. And I think everyone on this call understands that the actual number of cases is substantially more. We believe there was a point in December and January when literally 1/4 of the population of the world had COVID all at the same time, the largest infectious disease epidemic at the same time that has ever been recorded in human history. So incidence rates overall, they vary by whether or not someone's been hospitalized, also by whether or not they've been vaccinated. So of the non-hospitalized cases, it appears that 10 to 30% of people will have some ongoing symptoms, that as high as 50 to 70% of people who've been in the hospital can be affected. And then note the smaller number, 10 to 12% of people who've been vaccinated. And to my mind, one of the additional arguments for those of you who are trying patiently to talk to the vaccine hesitant patients that we care for, avoiding long COVID is definitely an additional incentive in my mind. It can occur at all ages, in acute phase, disease phase severities. The highest percentage of diagnoses across all ages appears to be in middle age, 36 to 50. And the majority, because there's so many more patients who are actually not hospitalized, 80% of people are outside the hospital with their COVID. The majority of long COVID cases actually come from non-hospitalized patients who've had a mild or no acute illness. And then again, patients with risk factors for more severe acute COVID-19 also appear to be more at risk for long COVID. So I was part of a group that did a literature review in the fall, looking at not only the incidence of a variety of different types of long COVID or PASC, but also the frequency with which it was severe. And we used a variety of different definitions for severe, meaning disabling and keeping somebody from work, requiring new or ongoing hospital care. So a variety of different definitions. And it was as high as 6 to 18% of all the different types of long COVID. Definitely, that was a higher number if someone had been hospitalized. It was also clearly more common in those people over age 65. And the argument we made in this editorial was that this is a major contribution to the severe manifestations of COVID-19. Up until this point, we'd been using our respiratory definition of hypoxia or admitted with pneumonia as the criteria for severe COVID. And it's clear other organ systems can be involved, and long COVID itself is causing high morbidity and a strain on health systems. If we think of pathogenesis, that would be a whole nother webinar. I won't take you there, but it includes such thing as immune dysregulation, the gut microbiota, as has been seen in early phases with HIV, appears to be involved in some patient populations. There's autoimmunity and immune priming. There's disruption of the endothelial cells and blood vessels and clotting mechanisms. Those two things have led to clots and a presentation with a cold limb or strokes or heart attacks. And then central nervous system alone, dysfunction with anosmia, with direct infection of cells in the central nervous system, and disruption of neurological signaling, including autonomic dysfunction. And I think you can tell right away from this list of very diverse causes of long COVID that it's probably not one thing, that long COVID is a wastebasket that's including several different mechanisms of pathogenesis and therefore are likely to be treated by quite a varying range of infections. And I will say that chronic infection with SARS-CoV-2 which is not common, has been associated with some of these symptom complexes in some patients. So there are some reservoirs of SARS-CoV-2, for example, in the gut or in the central nervous system that can be associated with prolongation of symptoms. So if I break that down, and again, there isn't really time to go all the way through this, but you will have these slides and access to them. This was in a beautiful review in Nature Microbiology in 2023 that tried to relate the symptoms to underlying pathogenesis, chest pain and palpitations related to either myocardial infarction, myocarditis, or postural orthostatic tachycardia syndrome, POTS disease. There's cough and dyspnea related to abnormal gas exchange and the development of pulmonary fibrosis, immune dysregulation, as I mentioned. There is a syndrome of acute pancreatitis and also incident diabetes or worsening of diabetes, a variety of different GI types of signs and symptoms with full presentation of gastrointestinal illness. I mentioned the CNS effects with not only dysautonomia, but the ME-CSF chronic fatigue syndrome complex, which has real similarities to some of the phenotypes associated with long COVID. End organ damage, including liver, kidney, and spleen, the blood vessels that I mentioned, with microclots that seem to be accountable for some of the problems that have been associated with myocardial damage and stroke. And then reproductive system abnormalities with erectile dysfunction, with disrupted menstruation as a result of hormonal imbalances. There has been association with reduced sperm count. So this is a long list, and this is just sort of the tip of the iceberg that I'm sharing with you. So there's a huge development of a research complex that's looking at this. So looking at what we do know, what we can say about some of the long COVID outcomes, some of our best data has come from Israel, where they've had an enormous long experience with a very centralized health system. So looking at people over a period of a year, almost 2 million citizens, those symptoms that were still present at a year included smell and taste abnormalities, brain fog, memory and concentration problems, shortness of breath, weakness and fatigue, dizziness, and interestingly, a signal for streptococcal tonsillitis. Again, it was the middle age group in this cohort that was most heavily effective, although shortness of breath was more common in the elderly. And again, the signal that in this patient population, those who were vaccinated were less likely to experience dyspnea. So another argument for earlier vaccination. Very importantly, because this covered the early phases, there was no difference between the wild type alpha and delta variants. And again, the sense of some relief that for those experiencing long symptoms, most people had that in a mild degree and improved over time. So we also had a very nice couple of studies looking at breakthrough infections and the incidence of long COVID in people who had vaccinations. And so this was in this one Israeli study where you can see overall about 1,500 people who were vaccinated with the Pfizer vaccine. There were only 39 breakthrough infections in this group. So that's the good news is only 2.6%, but 19% of those individuals had persistent symptoms beyond 6 weeks. And in a study in the UK looking at 1.2 million users who were reporting dutifully on the presence of having gotten their vaccine, first dose and second dose, almost 1 million people, that a vaccination was associated with a 50% reduction in the incidence of long duration symptoms that lasted over 28 days. So I take this to be, and I share this with my patients, that one of the reasons, strongest reasons to my mind for a vaccination is to avoid this uncertainty with long COVID, which really can be very debilitating, not only physically, but the uncertainty of where it's going, how long it will last, with its variability, takes a mental health toll on patients. And this was another meta-analysis that tried to pull together 17 different studies looking at vaccination and long COVID. And in this case, vaccination before SARS-CoV-2 infection reduced the risk of developing long COVID, and 2 doses were seen to be more effective than 1. And that was a durable effect. And then more recently, again, this is a preprint that showed looking specifically at the impact of treatment of nirmatrelvir and ritonavir in the VA, patients treated from May to June of 2022, of whom almost 56% were vaccinated and boosted, and then 24% had only had 2 vaccines, and then 16% were not vaccinated. You can see overall that the risk of PASC was reduced 26%, the risk of hospitalization 30%, and the risk of death 49%. So a 26% reduction in the likelihood of long COVID, to my mind, is another terrific benefit of the use of treatment. And so I often will tell people in the argument of whether or not they should take nirmatrelvir ritonavir, it's not only to prevent this acute hospitalization, but there's a 25% reduction in the incidence of long COVID. This was another one of the preprints from the nirmatrelvir group showing per 100 prescriptions of nirmatrelvir and ritonavir, 2 fewer PASC cases. And I've had a lot of discussion with clinicians. Many say, well, that's only 2 out of 100. That's a lot of people treated for a small number of benefit. But in that same group, there were 1 fewer hospitalizations for every 100 treated persons between 30 to 90 days of infection. So it's a double benefit of reducing hospitalizations and reducing the incidence of long COVID. I definitely don't have time to go over this list, but I'll share with you sort of what I think is exciting in the literature for attempts at studying therapies that are targeting some of the most promising studies. For example, using pacing for people who have severe dyspnea and fatigue for their cognitive dysfunction, the use of autoimmune acting agents, the BC007. For POTS disease, there are a number of therapies available like beta blockers and compression stockings. This is largely supported by the POTS literature and by the chronic fatigue syndrome literature. And so I think we're learning a lot from the 2 diseases are overlapping to some extent, and that's been very helpful. For the GI symptoms, not surprisingly, there's an active group looking at probiotics. For viral persistence, there are reports of individuals in small groups where antiviral therapy, nirmatrelvir in one case, valacyclovir or valganciclovir in another case, have been associated with individual benefits. None of these are proven to be effective. I'm not recommending them. I'm only sharing with you that these are what are being studied. For the dysautonomia, for example, there were some glowing reports of stellate ganglion blockade, which impacted some of the symptoms with dysautonomia. And also transcutaneous vagal stimulation is now entering clinical trials. And then anticoagulants and apheresis have been used in some of the abnormal clotting mechanisms. And it's just a set of studies in their infancy that I hope will bring benefit to our patients. And so I want to finish with this section, and then we'll try to take our little bit of remaining time for the remainder of your questions. So again, this definition, something that occurs after the first month, up to 3 months, and lasts for 2 months or more is the WHO definition. It's affecting a large number of people, anywhere from 10 to 30% of non-hospitalized patients. And for hospitalized patients, half or more, and 10 to 12% of vaccinated patients. And we saw examples where severe cases occurred as many as 6 to 18% of patients. We've seen some evidence that vaccination can reduce long COVID by as much as 25 to 50%, and also some early evidence of benefit with antiviral therapy, though the results there are mixed. We've also seen some studies where it wasn't so clear that it was having that impact. And there's so many research questions, there are too many really to list, but it certainly is, for those folks who are severely affected, a very pressing need for more data.
I'd like to thank Dr. Sherer and Dr. Vu for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on best practices for early outpatient COVID-19 diagnosis and antiviral treatment, On the Clinical Care Options Practicing Clinicians Exchange and ProCE websites, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.